Our next speaker is Dr. Ridge, who is going to present non-paraneoplastic erythema gyratum repens.
Good morning. This is the case of a 65-year-old female who presented to us last July with a 5-month history of a widespread itchy rash. Her GP had been treating her in the community as eczema. This lady was a previously healthy, non-smoker, non-drinker, taking no regular medications. It's important to note that this lady had a significant family history of cancer. So her daughter died of ovarian cancer at age 16, and 2 of her sisters had breast cancer in their early 50s. So on examination, as you can see, there's erythematous gyrate concentric bands arranged in parallel with a fine trailing scale. It's involving her upper limbs, lower limbs, and trunk. So our working diagnosis at the time was erythema gyratum repens, and our differential diagnosis included tinea imbricata, erythema annularis centrifugum, and an EGR-like eruption. So this is where a different dermatoses mimics EGR in its clinical presentation, for example, of vasculitis. So we began with a paraneoplastic workup, and all of our routine bloods were negative, and we did a CT neck and TAP, which was negative for malignancy. So we did 3 punch biopsies and a DIF. This first image here is a low power view, and then this image demonstrates the thickened and irregular epidermis with acanthosis and parakeratosis, and this then demonstrates the lymphohistiocytic perivascular infiltrate. So these histological features are all non-specific, but in correlation with the clinical findings, they are supportive of a diagnosis of erythema gyratum repens. And although the histology is non-specific, it is useful because it helps to outrule mimickers of EGR. So initially we treated her with topical steroids and topical antifungals, but when we brought her back to clinic 2 weeks later, there was no improvement. So we then expedited a further paraneoplastic workup, including a full body PET CT, which was negative. We did tumor markers, paraneoplastic antibodies, upper and lower GI endoscopy. So the endoscopy was negative for malignancy, but what's interesting is it did demonstrate a severe pangastritis, which was CLO positive, and this indicates an active Helicobacter pylori infection. So she was then placed immediately on triple therapy eradication for H. pylori, and this consists of amoxicillin, clarithromycin, and a PPI for 14 days. So as you can see here, towards the end of the course of triple therapy, her skin did improve, and she's clear of erythema gyratum repens following the 14-day course. Okay, so this, just to summarize, this is a lady who presented with erythema gyratum repens, who has no identifiable malignancy to date, and her skin remains clear 12 months following antimicrobial therapy for H. pylori eradication. So erythema gyratum repens is an extremely rare clinical entity. There's 83 cases reported in the literature to date, and historically it's thought to be a paraneoplastic phenomenon, but more recently in a review of the literature in 2014, the association with malignancy is actually thought to be lower than previously reported. It can precede the diagnosis of malignancy of a mean period of 7 months and up to 72 months, and the treatment is aimed at treating underlying malignancy. So with regard to non-paraneoplastic erythema gyratum repens, there's 25 cases reported in the literature. It's most commonly been found to be idiopathic, but it has been associated with PRP, psoriasis, ichthyosis, and there's 1 case of drug-induced erythema gyratum repens from azathioprine. There's never previously been any association between H. pylori and erythema gyratum repens, and it's never previously been reported to have cleared following antimicrobial therapy. So although Helicobacter pylori itself is a benign entity, it's interesting that it does eventually lead to malignancy. So it can lead to either gastric cancer, adenocarcinoma or a malt lymphoma. And again, what's interesting is that the treatment for malt lymphoma is actually H. pylori eradication therapy. Although our patient did have stomach biopsies which were negative. So obviously the pattern of EGR on the skin is very remarkable. And there's 1 paper published in 2015 suggesting a hypothesis between linking EGR and L-glutamine. So L-glutamine is an amino acid which is required for cell proliferation in the body. And in a cancer state, your L-glutamine levels are raised. So this group put L-glutamine into an aqueous solution, and it's self-assembled into rings. So you can see here that it's quite a similar pattern. So then, just to summarise, this is a case of erythema gyratum repens, which to date has been non-paraneoplastic and is improved following antimicrobial therapy for H. pylori eradication. However, we're going to follow this lady closely, particularly given her strong family history of malignancy, and bearing in mind that erythema gyratum repens can predate malignancy up to 72 months. Thanks.
Any questions or comments? No? Do you have any questions?
I had some, but you've answered them all.
Yes. Oh. There's for somebody, yes.
Sorry, I may have missed it. I think the family history was ovarian cancer.
Her daughter had ovarian cancer and 2 of her sisters had breast cancer.
Have you done anything like BRCA or other
So
genetic testing?
She's going to see the genetic team, but they wouldn't do the BRCA testing unless she herself had breast cancer or her sisters had been BRCA positive. So
Right.
yeah, we sent her for testing.
Yeah, I mean, there are lots of other ones as well, but
Yeah.
it'd be interesting.
Yeah.
Thank you.
And did they have anything to say about her daughter having had ovarian cancer at 16? Because that's
It's
unusual.
unusual, yeah. No, we don't really know anything about that. But it is unusual, definitely. I think that's why we chase the malignancy so much.
Must definitely be associated with BRCA.
BRCA, yeah.
Okay.
Any more questions? Right, thank you.